All right, welcome everybody. We're going to get started today. I'm Shannon Barris, Neuro-Ophthalmology here, and it is absolutely my pleasure to introduce Heather Moss. She's a professor here in both neurology and in ophthalmology. She began as a physician scientist at Harvard Medical School, where she earned her MD, and in combination with MIT, she completed her PhD in engineering sciences with medical physics. She completed her neurology residency and neuro-ophthalmology fellowship at the University of Pennsylvania. At Stanford, she pretty much does it all. She's a busy clinician, the director for our Neuro-Ophthalmology Fellowship Program. She's the vice chair of clinical research for Stanford Ophthalmology, and she directs the Moss Lab at the Spencer Center for Vision Research. But the real reason I'm actually still her friend is that she is the president-elect for the next 2 years for the North American Neuro-Ophthalmology Society, which means she is almost the most powerful person in charge of the largest society in the world for our specialty. We keep close friends. That is the highest honor, as it speaks to not only her intelligence, but her ability to organize, lead, and teach with exemplary professionalism. With Dr. Moss's innovative edge and engineering background, it is no surprise she is an expert in the application of artificial intelligence to enhance clinical care. So welcome Dr. Moss here, who will be speaking on deep learning and AI in neuro-ophthalmology. What is the clinical utility?
Thank you very much. I feel like I should just leave now because it's only going to get more disappointing. But thank you, Dr. Barris. It's a pleasure to work with you, and I keep you around as a friend because you're awesome. So it's my pleasure today. Jose Eduardo reached out to me about giving this talk because of an editorial I wrote in JAMA. And it's an area of deep interest to mine. I think it piques my engineer interest, but also my clinical interest and my operations interest, because there's so much exciting stuff in the world of machine learning and AI. But really, to me, the question is, how do we make this useful clinically as opposed to saying it's cool? And I realize I probably should have called this ophtho-neurology to make the audience more comfortable. For most of the stuff I'll be talking about today, I think we could say it's clinical utility of optic nerve analysis. So we'll focus on one nerve today. So these are my disclosures. And then I have a few acknowledgements. So these are people, all neuro-ophthalmologists who I really admire and think deeply about AI and models in neuro-ophthalmology. Dan is now in France and has led a lot of the groundwork in fundus photoanalysis for papilledema with the Bonsai project. Kevin is a computer scientist turned neuro-ophthalmologist who's in Indiana, is just a really deep thinker about these things. And Kelvin's a neuro-ophthalmologist from Singapore who is on sabbatical for a year in my lab, and I've really enjoyed the conversations I've had with him about some of these ideas and how we might implement them. So here's the basic problem in neuro-ophthalmology. We have humans like Dr. Barris and I'd like to think that we're intelligent. But there is more and more knowledge that's happening. Our time is getting pressured. There's a shortage of neuro-ophthalmologists, which either of us can talk about at length. And so the net result is you end up with unhappy doctors and a pile of patients clamoring to be seen. So could we somehow add artificial intelligence to supplement that? And the question is this going to burn down the whole system? In which case we should not pursue it, or is this going to be great and Dr. Barris and I can go lounge on a beach chair somewhere and approve AI evaluations of our patients? So what I'd like to do today is think a little bit about this, but first take a step back and put this in something we're all very comfortable with, which is that machine learning, deep learning, and AI models are really just another kind of model or system that we use in our medical practice. And I'll try and give you some examples to build up to that, so that it's doesn't seem so different. The second one is to start to think about it from a medical ethics perspective, that I think grounds us in our profession. And then the last thing is to think about how these things might help us lead happier lives, better patient care, more collaborative care, and improve patient access. So 2 take-home points if you're going to phase out or go get another pastry or check your messages. First point is that deep learning and artificial intelligence, I'm drawing a line between them, but there's not really a line, are really just other kinds of predictive models. And we use predictive models all the time in medicine. from traditional diagnostic tests to regression models. And then we get into deep machine learning. For that, I'm referring to things that use neural networks, and then generative AI, all just models. Second take-home point is that in order for us to use these models in an effective way, no one looks at a linear regression equation and just puts it into clinical practice. These all work as part of systems in medicine. And a system is going to have some input to the model, and then it's going to give you some output to the model. And because there's a system, we have to interact with them as humans. So we, maybe the same person interfaces with the model, and then another person or the same person interprets the output from the model. And from an even bigger perspective, these people are going to operate in the healthcare system. So how are you going to get this input to the model? Is it on your phone? Is it part of Epic? Is it some other system you have to log in? And then similarly, how do you get the output? So this is highly simplistic, but I think makes the point. So consider a patient you have. It's a 25-year-old woman. She presents with decreased vision in the left eye and pain with eye movements. Back of the eye looks pretty normal, but she's got a relative afferent pupillary defect. You get an MRI, and there's enhancement of the optic nerve. And so your clinical question is, do I need to be worried about NMO? And so you know from your learning that there's a test you can order for that. And so you order serum, draw serum, and the NMO IgG titer is 1 in 80. And the model for this, which is just a normal range, very simple, is this, if it's like, well, if it's less than 1 in 10, it's normal. And this is 1 in 80. So that is positive. And then you can go on and implement your clinical, what are you going to do with that? She has NMO, you can start treatment for that, et cetera. But thinking a little bit, how was this model built? How did we know that this was the normal range? And then how was this model tested? And for a lab test, it's reasonably straightforward. So various people took a number of people with the disease and a number of people without the disease and looked at the titers of the test and figured out the sensitivity and the specificity. And then someone put that all together to figure out the normal range. Then the next question is, what's the system around this? So you don't have to draw the blood and go to the lab and measure it. You order the blood test, a nurse draws the blood, it goes to the lab. There's a results page that someone has figured out how to generate in Epic or as a scanned piece of paper. And then how was the system tested? Relatively recently, to order MOG, for example, antibodies, we had to do an unlisted test. It was a real pain. It would come back as a fax. You had to click 5 places in Epic in order to see it. And now it's integrated, so it all comes through in the electronic information. And so that's been the evolution of that. All right. So I won't belabor the lab test example, but that's sort of a very simple model. So let's think of a slightly more complicated model. So a patient comes in with transient visual field loss, says they were eating dinner, suddenly they couldn't see to the right, they covered both eyes, they're sure it was both eyes, it was the right field, and then within 15 minutes it got better. And so they come to the ER. And so the question is, what is their risk of stroke based on this possibly clinical TIA? I realize that the ABCD score is an older one and there's newer ones, but this is a little bit simpler to explain. So you know that there's this ABCD score that will predict stroke risk. And so you look at the components, which is age, blood pressure, the clinical syndrome, and how long it lasted. And then you add it all up, and then you know the stroke risk level, and that can help you decide how urgently the patient needs the sort of the TIA workup. So how was this model built? It's not quite as simple as a normal range for a blood test. And then how was the model tested? So here's the answer, and somewhat surprising when I looked it up and read about it. So back 20 years ago, a group took a cohort of people who had probable or definite TIAs. Interestingly, they excluded people with monocular events. So this isn't valid for transient monocular vision loss. And the outcome was this cohort was followed for incidence of ischemic stroke. And the way they did the model building, so they didn't actually have a huge amount of data, is they just did bivariate Cox regressions for each variable. So they looked at age and incidence of stroke. They looked at systolic blood pressure and incidence of stroke. They looked at duration and incidence of stroke. And they didn't look at these in any sort of comprehensive way. They kind of picked a cutoff for duration and said, let's look at long and short. And then if the p-values in their Cox, again, their bivariate Cox regression was less than 1, they're like, that's great, we'll include it in the score. And if we have a variable with 2 categories like duration, we'll give the scores 0 and 1. If we have 3 categories, we'll say 0, 1, and 2, and that's our score. And that was as much statistics as they did. And then they sort of looked and saw if it worked. And so you can see that here are the initial, they had 4 cohorts. So one of them was used to train the model, so to develop, to do these sort of bivariate Cox regressions. And then the other 3 were used to test it. So at the bottom is one of the validation cohorts. And you can see that for, I know the font is small, but the point is if the scores were 3 or less, 0 of their patients had strokes. And so the risk was low. And then you can see that the risk went up in 7 days as people had higher scores. And then we've implemented this clinically. There's been advancements on it, and we've never stopped back to think how it happened, but it worked. So this is, in a way, is machine learning because we used math and statistics to figure it out. But what really gets exciting is when we think about unstructured data. So not just a number or a category, but what about images of great interest in neuro-ophthalmology because of the fundus, but also of great interest more broadly in neurology because of MRI and neuroimaging, and also unstructured text. We all write these really long notes that have all sorts of information in it, but you need to speak the language to understand it. So the big advance and what really made this idea of deep learning possible is the neural network models. And they're called neural networks because they are like neural networks in the brain. And so you take inputs, and then rather than just having very simple statistical relationships with the outcomes, they are networks. And so you have layers that figure out each other. And they learn, meaning that it's a bit of a black box. And so the way a deep learning model works is you take your inputs and you take your outputs, and then you run these different models to develop a predictive model that connects them reliably, but you don't have as much insight into it like you do with the ABCD model, where I can tell you exactly how they figured it out. So very similar to our classic statistical models, you need training data to figure out your model. You need testing data to figure out if the model works outside of that training data, and then you need to validate it, usually with more data. The difference here, and the reason that it's newer, is that it's much more complex. It costs a lot more in terms of computing efficiency. You need a lot more data. And it's not as transparent. So I can tell you exactly how the ABCD is built, but with this, it's a little bit of a black box in how it connects together. And then similarly to those other models, you still need to have it in the context of a system. So how do the people interact with it, and how does it exist in terms of the total health system? So now a patient comes into the ED and they have headaches and blur. Let's say that it's a 30-year-old woman, and she's, says she's got this new headache. It's worsening over the past few months, and blur, head imaging is negative. And so the question is, does this patient have papilledema? Am I worried about high ICP? And so the excellent thing that would be helpful to you in the ER, because the pupils are small and you don't have a panoptic with you, and the ophthalmologist is over at the VA, so they can't get there, is to have a fundus photo, which you can then put into a neural network deep learning model. And the output can tell you, does this patient have papilledema or not? And then that can help you to clinically care for the patient. And indeed, this model exists. We had the great pleasure a while back of having Valerie Buse here to give Grand Rounds, and she talked a lot about this idea of having fundus photos at point of care in the ER to help make more rapid decisions. So this is a little bit of review, but I have a few different comments to make. So the Bonsai model was built from 24 different centers, and they collected fundus photos of the optic nerve, almost 10,000 of patients with clinical papilledema, so high intracranial pressure, 2,500 patients with normal optic nerves, and I should actually not patients' eyes, and then over 3,500 with other optic disc anomalies, so other swollen discs, pseudopapilledema, et cetera. And they built their model in 2 steps. So the first step was a segmentation task. So the task that the model was given was find the optic nerve to focus the model to where it needed to look. And you could think of this the same way you would teach a medical student to look at an MRI. They don't just start scrolling randomly. You show them where to start. You show them an approach. So it showed the model an approach. And then the second part of the model is the classification task. So now that we know where the optic nerve is it normal? Is it papilledema due to high ICP? Or is it another optic nerve abnormality? And to address the challenge of this black box, because everyone gets worried that the model's just kind of being lucky, they generated heat maps, and the heat maps show where the model is looking. So down here is sort of where the model is focusing to make that distinction. And the results are pretty impressive. So the primary validation data set, which was a set of the testing data. So what they did is they took all of these centers, they reserved a couple of centers to be external. So those centers didn't contribute at all to the initial training data. And then the rest of them, they split. And so we weren't a participant, but let's say we were, like 75% of the Stanford data would be used to build the model, and then 25% would be used to test it. And then UCSF wasn't included at all in that and would be used as external validation. So what I've highlighted here, the top one is in the primary validation data set. So that's from the same pool of data that the model was built on. And you can see it's pretty impressive. We all like to use AUC, which is probably the most forgiving area under the curve metric, and it's 0.99. So that's really impressive. And the sensitivity and specificity are pretty good. The accuracy is pretty good. When you move it to the external testing set, which may have some systematic differences and is why it's important to have it be separate, you can see it goes down a little bit, but it's still 0.96 for an AUC. That's a really good classification. However, the accuracy drops to 87.5%, specificity 84.7 point estimate, and sensitivity 96.4. Still pretty darn good, and I would say probably better than most medical students. Apologies to all medical students in the room. So the question is this good enough? Is this good enough for us to put this on the front line and have us make patient? And that requires diving a little deeper into the data. So the highlights, if it's too long and you're not reading it, is on the right. But essentially they said, okay, in our external data set, we had 360 eyes with papilledema, and 5% of them were incorrectly classified. And that's what we're really worried about. We're worried about missing papilledema. If patients who we labeled as papilledema turn out not to have it and they wait for ophthalmology to confirm it, that's not going to negatively impact their clinical outcome. So of those were 18 eyes. And so first of all, sorry, it's not, but 18 of those eyes were incorrectly classified as other optic disc anomaly. And so their argument is, well, we still would have classified these as abnormal, so we wouldn't have missed the pathology because then a person would have looked at it. And in fact, when they looked at these 18 eyes, they discovered that the deep learning system was actually correct. It was the labels that were wrong. So what was the gold standard was actually incorrect. So those were actually fine. So there were 15 eyes that missed it, that were labeled as normal. And then when we went back to the patient level, they found that 13 of those patients had a fellow eye that was correctly classified. And so that patient would still be labeled as papilledema, even though the one eye was not. And so at the end, they said, well, actually, we only missed the diagnosis in 0.6% of people, only one patient in this external data set, which is pretty darn good. And then they calculate that if you consider what we're really worried about in clinical practice is the positive predictive value, and if there's 10% papilledema prevalence, remember by just pure chance, your negative predictive value would be about 90%. The model gets the negative predictive value up to 99.6%, which is darn good. So should we implement a system clinically? And I want to go through a few questions, which we'll come back to for other examples. So does it address a clinical need? Yes, these patients are showing up in the ER. It's hard to do an eye exam at the bedside. We could get a photo and answer the question and maybe save them, stay in the ER, a lot of extra tests, a lot of anxiety. Is the risk mitigated? Does the model do a pretty good job? And I would argue in this case, yes, it does. And we also have a backup plan. So when there's a question, or even all patients, the photo could be reviewed by a person. Subsequently, the patient can be examined by a person. This is a judgment that a trained person can make. Is a system feasible? So you can go back and watch Dr. Bios's Grand Rounds talk on Zoom, and she'll talk about what they've done to set up fundus photography at the front line in the ER at Emory, and a lot of other centers are doing this as well. It's incredibly hard work. Even just trying to set up the fundus photo machine in the Neurodiagnostic lab, which is now there, I can tell you we've been circling around with the Epic orders for months. We've been trying to get the photos to a place that I can see them in the right way. There are lots of barriers that are there, but they're all very doable. There's ways to get the results to the doctor. No one has yet implemented the deep learning system in analysis of the photos, but that would be the next step. So is a system acceptable? Yes, in these centers that have done it, the idea of having frontline fundus photography that's read remotely by an ophthalmologist, people are accepting it, and presumably they will accept the AI model, but that all remains to be seen. And this gets to the point of acceptance. So you could have the best model or the best test in the world, and if people don't accept it, if doctors aren't willing to use it, if patients aren't willing to believe it, then that's not really a useful system. So we're going to go to another part of the body that we rarely think about, the GI system. And I'd like to thank Kelvin for pointing me to this article. So this was a survey of gastroenterologists who have a few systems in place to help with colonoscopy image analysis. And what they asked, so the CAD-E, CAD-X, and CAD-I, which are on the x-axis, are just 3 different kinds of image analysis that they use. And what they asked them was what they perceive the risk to be. And so a lower score means they perceive it to be less risky. A lower score means they perceive it to be less acceptable in the middle lots, and then a lower score on the right is that they have less trust in it. And first of all, you can see that the distributions are pretty broad when they surveyed. So there's going to be adopters and there's going to be people who are a little skeptical. But what was particularly interesting and surprising is we tend to think that the younger generation will be more accepting of things, that are a little more black box, perhaps based on sort of advances in computer science. But what's particularly interesting is if you look at this left plot here, which is looking at perceived risk, there's a difference. The red are people with 10 years or less of experience, and the gray are people with more than 10 years of experience. And so it was actually the more senior physicians who perceived this to be less risky. And the thought was that they were more comfortable with catching the false positives or catching the false negatives. And so they saw the system as one that could help them be more efficient, but that they still felt that they could provide some supervision over, whereas the younger physicians were concerned that perhaps it might sort of divert them in the wrong way, or that they might miss something. So far we've talked about things, this papilledema versus not, that I'm sure many people in this room with a good fundus image could make that judgment themselves. As I said, some of the fundus photography systems that are in ERs are being read by humans. So reading that photo is a human problem that can be solved. But one of the real excitement about some of these models is, well, can the system make judgments that human can't? So there was a Google system that was very exciting now a number of years ago because it could figure out gender and age from a fundus photo. And I cannot, Dr. Barris cannot, the most experienced ophthalmologist cannot do this. So let's think of something that's a little bit tougher. So consider you have a 75-year-old man comes in with sudden vision loss, the left optic nerve is swollen. And so there's 2 main differentials here. The right eye is fine. Is this a non-arteritic anterior ischemic optic neuropathy, sort of small vessel ischemia of the optic nerve head, or is this giant cell arteritis, which needs urgent intervention? And so what would be super helpful in this case is, again, sort of a fundus photo analysis system where you input the photo of the swollen optic nerve, you run it through a variant of the Bonsai model, and then at the end it spits out, this is non-arteritic anterior ischemic optic neuropathy, or this is arteritic, this is GCA, and you better do something. And the Bonsai team, fresh off their great success in New England Journal of Medicine article with papilledema detection, has moved on to other things. And so they looked at this, could you differentiate arteritic from non-arteritic? Now, All of us in neuro-ophthalmology can give lots of talks and talk about the typical things that show arteritic from non-arteritic and optic nerves. But for me, I would not base my diagnosis just in the optic nerve analysis. So what's interesting in this model, 21 sites, 961 eyes, they allow different cameras to be used, which improves the generalizability. And these are the results. So for some reason, it was put in an E-table, so it's not as nicely formatted. But again, when you look at the sensitivity, specificity, accuracy on the training, that's really good, not surprising, because that's what the model's trained on. The internal validation is a little bit worse. But when you look at the external testing, the area under the curve is 0.97, again, excellent. When they compared it to experts, so 2 expert neuro-ophthalmologists were given the same pictures, and the accuracy of the model was 93%, and the accuracy of the neuro-ophthalmologist one was 74%, and the other one was 82%. So in this particular case, the deep learning system did a lot better than the humans did. And then I've highlighted for the people versus the machine, the number of false positives. So you can see that the 2 neuro-ophthalmologists missed a substantial number of GCA cases and inappropriately diagnosed a number of GCA cases. So model missed 9% of GCA cases versus 33 to 47% for the experts. And the model overdiagnosed, which is probably not as big a problem because we have other tests, 6% of patients compared to 11 to 15% of the experts. But the question is this good enough? I'm super impressed that a model can be trained and can make this distinction, but missing GCA in almost 10% of patients, that's problematic because those people, if not treated appropriately, could go on to lose vision in the other eye, have strokes, have other morbidities, and this is a disease that we have treatments for. So should this system be implemented clinically? It addresses a clinical need. GCA is my least favorite disease because I never know, and I'm sending them off for biopsies, and I'm putting older people who have diabetes on steroids. Like it's not great. So if some machine could tell me this is not GCA, I would love that. But in this particular case, I really don't think the risk is mitigated. I think missing 9-10% of cases is not okay. And although it's better than experts, which is super exciting, it's also important to remember that the gold standard was clinical diagnosis. And nobody diagnoses GCA by looking at a fundus photo by itself. And so are there ways around that? Is a system feasible? Yes, it would be another fundus photo-based system. And is it acceptable? I think that's something to be determined. So for example, is GCA, does it even need a fundus photo, or are we doing okay clinically based on other metrics? So to talk about this idea of sort of adding other things to models, making them multimodal, which is the way we work clinically, I wanted to highlight this paper by one of our ophthalmology faculty as the senior author, Sophia Wong, who's done a lot of work. This is looking at glaucoma. In neuro-ophthalmology, we always looked at glaucoma research because that's the most common optic neuropathy. And so they're usually a little bit ahead of the curve in terms of what they're doing. And this came out Wednesday, so just in time for this talk. So Sophia is very interested on the idea of fairness of models. So we're always concerned about generalizability, but also of bias in our clinical care. And one of the concerns with these black box deep learning models is, are they fair? So the AUC looks great, the predictive values look great, but are those behaving the same? So this paper is really interesting. I advise you to have had at least 2 cups of coffee when you read it. So I will just try to highlight a couple of things, and the QR code is there. So what they did is they built models, and they were looking at, do people with glaucoma go on to need surgery? And they trained the models 3 ways. So they were specifically looking at demographic variables. So first version of the model, they only included their 179 glaucoma predictors, did not include race, gender, and ethnicity. Second model, they included the sensitive attributes. And then the third model, they actually did different models for each category of what they called sensitive attributes. So I'll show the gender results here. So model 1, and this is the 3 different test sets, internal, external 1, external 2 in different colors. And the left group of bars is male, the right group is female, and they're in groups of 3, and this is the performance of the model. So what you want to compare is the bars of the same color in each group of 2. So in the first model, when they didn't include gender, you can see that the model for female, for the internal test set performs a little bit worse, for external performs a little bit better, and for external 2 performs a little bit worse. And this is, again, the model did not include sex. So this was only including their other predictors, but it did still perform differentially when you looked at the patients by sex. Model 2, where they included sex in the model, the overall model, you can see again, there's some differential performs best on the internal testing set. And then model 3, which is where they did different models for male and female, you can see that overall a little bit lower than the whole models, and still a little bit of difference. So the accuracy doesn't change a whole lot. You can see the blue bars all kind of look similar. The orange bars all look kind of similar. The gray bars all look kind of similar. But the people who are thinking deeply about this have defined what fairness means. What does fairness mean in a model? I just wish I could decide what fairness meant for my children, because they seem to feel that my definition is flawed. But the basic idea of how you figure out fairness in a model is you compare the rates of false positives and true positives between your groups. And I won't go into this too much. Again, after your cups of coffee, you can read the article. But the take-home message is that for these odds that they're measuring, lower is more fair and higher is less fair. So in the internal test set, and when you excluded the sensitive attributes, you can see that the model is less fair than if in the black bar, the second model where they included the sensitive attributes. And interestingly, when you do separate models, you actually make it less fair. And when you looked at the other test sets, the 2 other external test sets, you can see that it varies a bit as well. So the fairness varies depending on the modeling strategy, and the fairness does not generalize to external test sets. So this suggests that including other factors in models can be helpful. So perhaps for the GCA perspective, we could include things like sex, ESR, CRP, lab results, does the patient have a headache, what is their age, together with the fundus photograph, and that might raise it up and get rid of these false negatives that are really concerning to me clinically. But what this really emphasizes too is that when we're dealing with these black box models, there is the potential for unintended effects. And so we want to make sure that there is fairness, that the model is consistent, and that it does generalize, that when we train a model with Stanford data, which is what a lot of people do, they use their internal data, that when you go out and deploy it, even at UCSF, just a few miles away, that it continues to perform adequately. So we were talking a little bit about how do we use unstructured data, so images or unstructured text, and could that do better than humans and models? And turns out the models can do better than humans. But what if we take it a step further? Why are we the arbiters of the categories? So yes, when you're thinking of a disease, you want to know if it's a disease or not, but there might be other things that maybe we've categorized incorrectly. And so think of the question, you have a patient with IAH and they have visual field loss, you measure it using a Humphrey visual field. And so you see the patient follow up and you ask the question, is the visual field improving? So the visual field has, I'm showing the grayscale here, but essentially it's like 52 different points that are continuous numerical variables. And we have all different ways of looking at it. And so the idea is that you take all of these points, you feed it into an archetype model, and rather than labeling the data and saying this is this and this is this, you say to the model, figure this out. And then you can ask the question, is it improving or not improving? And so the difference here is whether you're building a supervised model where the user is defining the classes and we use our expert experience, saying, yes, this is a change, no, this isn't, but it requires labeling the data. And as the models get bigger and bigger and bigger, this labeling is really problematic. Or you could have an unsupervised model where you just throw it all in and the model figures out the classes. This is kind of cool because sometimes the model has some insights that we as humans didn't have. And also cool because you don't have to label. So that's less work and less personnel effort on your grant. So here's an attempt to apply this idea. It's not super clinically relevant, so it's a bit of a stretch, but I think it makes the point and is a nice transition as we talk about the more generative AI models. So what they did is they took all the visual fields that were done in the idiopathic intracranial hypertension treatment trial, which is 52 data points that are continuous variables. And they threw it all into this model, this neural network, and the neural network said there are 14 different kinds of visual field anomalies. And these are just shown in sort of a red scale map here. And you can think almost, if you like principal component analysis, these are almost principal components. So all of these things are independent classifications of visual field. And so it reduced it from considering 52 independent points to say, actually, we can represent this data through 14 independent dimensions. And the way that that could potentially be useful is that you could take a visual field, for example, the one shown up here for a patient, and you can look at the mean deviation, which is the overall decrease in vision. You could say, oh, nasally, there's a little bit of constriction there. But what you could do then is you can map it into the space that the model has defined. And so they could say, well, 24% of it is archetype 1, which is essentially normal. 20% of it is this archetype 5, which is an inferior nasal step. And you can see how the other things add up. And then once you could do that, you could perhaps just look at the change in archetypes. And rather than look at the entire field as a whole and try to interpret it, you can say, well, this patient at follow-up had archetype 1, the normal, go from 25% to 67%, and this archetype 5 go from 75% to 31%. And so maybe for the specific question of papilledema from IAH, you don't need to look at the overall field and mean deviation. Maybe what you really need to look at is archetype 5, and that gives you a summary measure that might be more intuitive and might be more sensitive and specific for your patient. So should a system like this be implemented clinically? I would say that it's not really addressing a clinical need. It's not particularly hard when you're used to reading visual fields to figure out if the visual field is getting better or not. And so it's not a huge challenge considering what would have to be done to implement something like this. But I think it's kind of a cool idea. And maybe if we move to a direction where visual fields, I'm not proposing putting a visual field in the ER. If you've ever done a visual field, it takes half an hour and it's super annoying and painful. And so some of these questions about is risk mitigated, is it feasible, is it acceptable, are moot points right now because it's not really meeting a great clinical need. But what would really be interesting is if we could apply unsupervised learning to fundus photos and not have all these sort of classification tasks that we're doing now, where we as humans are building a separate model for every clinical question, which means that you have to know, am I doing the papilledema or not model? Am I doing the NAION or AION model? And then we're implementing all of those separately is going to be a little bit challenging. So the two big problems are, number one, we need more training data. So with the LLMs, the ChatGPT models, those are really powerful because they have all the text in the world that they've been able to scrape off the web. But medical image data is quite limited. So a lot of this is done with research grade data. So the images have been scrubbed to make sure that they're of high quality and not real world. And all of it is protected in our own health systems. We can go get IRBs, but there's no real way to go get all the fundus photos in the world. And then part of that, what's buried in there is the privacy issue. So there's actually some interesting initiatives where patients are uploading their images. I think it's mainly being done for CT scans as a way to create these image banks that can be trained on. And then the second problem is the model complexity and compute power. So I just showed you this archetype model for visual fields, and that was 52 points. An image is a lot more than 52 pixels. And if you add color, there's even more dimensions there. And so you just need a much more complex model. You need much more compute power. But welcome the technical advances of the past few years, particularly the transformer model, and then also the computing power, which has allowed us to build, and I say us like I had anything to do with this, has allowed the people at OpenAI and other places to build these large language models. And so these are still just models, but it's amazing what they can do. So as opposed to what I've talked about before, we're not just using 9,000 images of optic nerves, massive amounts of ordered data. So basically characters and spaces of text to build these large language models. And just to give you a sense, I showed you the ABCD model that had 4 parameters. GPT-3 had 175 billion parameters, and GPT-4 has 1.7 trillion parameters. These are massive, massive models. And the way you interact with them in a system is in a sort of a chat bot, but really this is no different from another model and system that I've been showing you. So there's a prompt and you give your input in text. The model gives you output. It also sort of internalizes the prompt to help it learn. And then you can give the model feedback and say, well, that's not actually what I was looking for. And in that way, the model can learn and adapt to you in this new and fascinating field called prompt engineering, which is kind of getting these models to do what you want them to do. And to draw another parenting analogy, liken it to getting my children to do what I want them to do. And I'm now getting pretty good at it. So to take it into our system and model, since we don't really have large image models at this point that we can use clinically, but we do have large language models and they're starting to pop up. I think you guys have access to the Copilot to sort of dictation and it will make notes for you. And this week, I know we just got access to it will script result responses for you for patients. So let's think about patient portal questions. So the need is, I hate my Epic inbox and I want something to answer the patient's questions. And so what if the language model generates an answer to the question and then it gives an output? So a group of us put together this study where very basic patient questions, sort of stimulated patient questions like, what are the side effects of Diamox? Or how do I know if I have GCA? We're fed into a bunch of different large language models. And then we're also fed to us, the experts, and we were asked to give a response. We were also given an AI-generated response, a large language model response, and asked to edit it so it would be more patient appropriate. And then we were given all the responses, so hundreds of them, and we were asked for questions we didn't answer, and we were asked to grade them in terms of quality and empathy. And this is the plot here. You can see that most of them did pretty well, sort of ending around 4. But the main take home is that both for empathy and quality, we, the experts, judged the AI, the LLM responses to be better, to be higher quality and to show more empathy than we did. In my defense, we were not asked to show empathy in the instructions. But what's interesting too, and it has made me actually be more thoughtful in how I write my patient responses, but what also was interesting is that what exceeded both the LLM models and the experts alone was when we were given the opportunity. So sort of this expert as AI. So should such a system be implemented clinically? It is feasible. We're already doing it, not quite for patient messages yet, but for lots of other things. It clearly addresses a clinical need in terms of burnout and a lot of the administrative paperwork. We can mitigate the risk by having us edit it. So looking at the sort of preview of it and being able to check. And it's obviously feasible. These types of things are being implemented. So how could we then get these kinds of systems to work for images? And I'll talk about a couple of emerging concepts that are happening right now. So one of them is the idea of foundation models. And the large language models are essentially foundation models. So you've trained on massive amounts of unlabeled data, and you sort of teach the model to recognize this type of data. So you create an unstructured model of a certain type, say images, and then you can use that bigger model to do the focus training and what you really want it to do. And this is kind of like the prompts and feedbacks that we do with an LLM model. And you end up with a specialized model, which requires a lot less specialized data than if you were trying to train it from scratch. So there has been a foundation model trained on retinal images. So they've used 1.6 billion or million, sorry, unlabeled fundus photos. Obviously, this isn't going to create a model with billions or trillions of parameters because you don't have that much data. But it's still it's sort of teaching, again, to look at the medical student analogy. It's teaching it an approach. This is what these images look like. This is how they differ. And then what this particular group did, and this also came out 2 days ago, is they took labeled fundus photos of glaucoma or not, and then used that to train this foundation model on the specific question of glaucoma diagnosis. And in addition to feeding it more images, which is shown on the x-axis here, they also re-exposed it to the same images. So you can think this as studying for your boards and looking at those same flashcards over and over and over. Eventually it sticks. And so the epochs is the number of times they showed it the same image. And you can see two things. Number one, you show it more images, it learns better, the model performs better as judged by the area under the curve. And if you just show it the same images more often, so you don't actually have to source more images for this, it also performs better. And so this is thought to be how we will be able to sort of really take fundus photo analysis to the next level, not have to do all these different models and source these thousands and thousands of images, because, and especially for neuro-ophthalmology, which is a small field and there's only so many NAION images in the world, this will help us to get systems that are, or models that are more reliable, have fewer false negatives, and can be implemented clinically. So another thing that's out there that's really interesting is this idea of visual language models. So I just was talking about how great the language models are and how impressive they are. We communicate about images through text. So we describe them verbally. When you're saying I look at a picture and have a judgment, but I'm describing it to someone else, I'm going to use language. And so what these visual language models do is they interact with a picture through language. So this is just a simple example pulled off of this Hugging Face website where there's a picture of two cats and you can ask it questions like, is one cat behind the other? Can you segment out the cats? What is the breed of cats? So these are sort of zero-shot questions where the model has no knowledge of this picture, or here's sort of one shot where you give it some information. Striped cats or tabby cats, what is the breed of the cat? And then it generates that information. So Kelvin, who I mentioned before and is in the back row, has been playing around a little bit with this. And what I think is super exciting about this is this was done on a laptop. So just a consumer grade laptop using one of these publicly available VLM models. And so what he did is he fed a publicly available data set, and we were using publicly available because of the concerns of privacy and that this is all based in the cloud. So you have swollen optic nerves and unswollen optic nerves, and they were given the model was given two prompts. So the first prompt was, what is this a picture of? And the models did not do great. 100% of them thought it was something to do with the eye, but sometimes it said iris, it never said optic nerve, and it never said swollen optic nerve. But then we tried to answer it a little bit of a better question. And to give it to prime it a bit. This photo shows an optic nerve. Does the optic nerve appear to be swollen, which is the clinical question? And again, this is off the shelf, a group of random photos run on a laptop. And the model was 77.3% accurate, 93.8% specific, and a little bit less sensitive. So this is pretty impressive, and I think shows the potential of these kinds of models. The other thing that's really interesting about this is that this is kind of how, in my mind, how we think clinically and is a bit more of an easier translation. So when we're looking at an image or we order a test, we're not saying, what is this fundus photo of? We're saying, I'm worried that this patient has headaches. I'm worried that they have IIH. Does this photo show papilledema? And this kind of system might be a little more nuanced and fit in with our clinical tests a little better, rather than knowing, oh, I need the papilledema or not classifier, or I need the NAION or not classifier. All right. So to sort of wind down and bring us all back to earth, I want to reinforce a couple of things and then remind us of our duty as clinicians. So first is, with all of these exciting applications of deep learning and AI, where I'm really using deep learning to say neural network models and AI to say transformer generative models. They're all predictive models, and ultimately we have to implement them, or they are implemented in clinical systems, which includes us as people interacting with them, patients interacting with them, and also how that is delivered to us. And so whether you're looking at a blood test like NMO-IgG, you're looking at a score, you're looking at photo interpretations or visual fields or a patient question, the model is helping you interpret that and then giving you various kinds of output, including normal, abnormal, a score, a classification, or a text answer to a question. And I think if we come back and think of it this way, it's a little bit easier to use all the tools that we have before in terms of thinking critically about test output results and positive and negative predictive value, rather than this overwhelming, like, this is really cool, but it's also really scary. So remember our friend Hippocrates here. So first, I think we really don't want to do harm to our patients. And how can we do harm? So this applies to all medical diagnostic tests. We can use it incorrectly. We can ask the wrong question. If I start ordering ESR and CRP on 12-year-old patients, like, that's not going to help me diagnose GCA. They don't get GCA. There's the problem of generalizability where you use the wrong model. So let's say you're using the wrong range of normal for a lab based on your patient's sex and age. There's a problem of inaccuracy. We really need to know with the tests that we get, what are the artifacts? What is a false positive? What is a false negative? I'm sure you get referrals all the time for things on MRI that are nothing. And you have the expertise to know that. And then we also have to think about the issues of privacy breach. As these models get bigger and bigger and are run in the clouds, are we uploading patient data to those, and what happens to that data? But there's things we can do. So one is there's system design with guardrails. So you don't just let anyone order the papilledema model, you require some guardrails to make sure it's being used for the right question. You can make sure that the models have broad training data and are broadly validated, really with end-to-end validation testing to see how it works. You can make sure that they are acceptable and use some feature and figure out if you can explain, give insights into that black box. And then just, again, be really knowledgeable about what's happened with the privacy. So to sort of zoom out from a higher level medical ethics perspective, we've talked about not doing harm, but we also want to do good for our patients. And I think there's lots of exciting potential here to advance medical care and improve access to care. We do want to make sure that patients' autonomy is maintained. And there is a little bit concern that if we're using these models and we don't understand how they work, how are we going to explain it to a patient so that they can understand and then have the information to make the decision? I talked a little bit about this fairness in AI. So are we causing more gaps in care? Are we actually going to create inequities? We thought with telehealth that was going to bring care to the world, and we actually saw that it perpetuated some of the inequities in access to care that are already there, and could this do the same? And then really one of the big challenges is feasibility. This seems exciting and computers seem cheap, but computing power is really expensive, and this is becoming more of an issue. So I'll leave it to you to decide, is this going to burn the whole system down, hopefully after I retire, or is this going to make life on easy street? And so do I put it out, or do I embrace it and take off? So with that, I will end. I just want to leave you with two sort of sets of references. So these are a couple of articles, now a few years old, which is ancient in the AI world, that was in the Journal of Neuro-Ophthalmology. And it really talks about some of these issues about building models and also getting them into clinical practice. And then from the Stanford site, there are some wonderful online lectures of YouTube. One about talking about how Stanford Health is approaching deciding what to build AI models of. And another one really talking about the importance of systems, and that the models shouldn't be getting all the recognition because it's really the systems we need. And if you're more of a text person, this is an editorial that Nigam Shah and David Entwistle published a couple of years ago, talking again about these large language models. So I encourage you to listen to those if you want more information. You don't need coffee to access these. And thank you.